If the fracture will be accessed by a transpedicular approach, the tools are contained within the boundaries of the pedicles. In the spine, using 2 inflatable bone tamps and a bilateral approach is recommended. This series presents suggested fundamental techniques for transpedicular access to a vertebral body. In practice, adjustments to the technique may be necessary to allow for anatomical variations and fracture configurations within a specific patient. Use fluoroscopy to locate the pedicle cutaneously with either a clamp or a scalpel in true AP view. An incision less than 1 centimeter in length is required. The incision is placed lateral and superior to the cutaneous pedicle location. This allows proper convergence through the tissues to the entry point on the pedicle. In the AP view, use the 11-gauge bone access needle to start at approximately the 10 o'clock or 2 o'clock position on the lateral border of the pedicle. The exact starting location will vary with fracture configuration and pedicle morphology. Switch to a lateral view to verify needle trajectory and position relative to the superior and inferior pedicle margins. Return to the AP view. Advance the 11-gauge needle such that the tip of the needle appears to be in the middle of the pedicle outline. Verify in the lateral view that the needle tip is midway through the pedicle. Return to the AP view. Advance the 11-gauge needle such that the tip of the needle is just inside the medial outline of the pedicle. Confirm in the lateral view that the needle tip is just past the posterior cortical margin. Remain in the lateral view. Remove the center stylet of the 11-gauge needle. Advance the guide pin through the 11-gauge stylus. Withdraw the needle stylus, leaving the guide pin in place. Advance the osteointroducer handle and cannula system over the guide pin. The osteointroducer should be advanced until the distal portion of the cannula is just past the posterior vertebral body wall. Depending on the bone quality, a surgical mallet may be used to tap the osteointroducer handle during insertion into the bone. To maintain structural integrity, do not advance the cannula without the osteointroducer handle inserted. The cannula has 1 centimeter markings, which may be used as a reference of tool depth. These markings are not intended to replace the use of fluoroscopic observation. Remove the purple osteointroducer handle and guide pin from the working cannula. To remove the purple handle from the cannula, press in the release tab. The precision drill is used to create a working channel for the Kyphon inflatable bone tamp. In the lateral view, use the precision drill and handle to drill to the center of the vertebral body. Only manual power should be used when advancing the precision drill. The precision drill has markings which give a visual indication of drill depth. The markings begin at the point where the distal tip of the drill exits the cannula. Thin bands are at increments of 2 millimeters and bold lines indicate each centimeter. Switch to an AP view. If the tools are converging correctly, the drill will appear to be equidistant between the medial pedicle border and the spinous process. Return to the lateral view and advance the drill to a point approximately 3 millimeters from the anterior cortex. Live fluoroscopy may be advantageous when approaching the anterior cortex. The drill should appear to be approaching or at the midline of the spinous process on the AP view. Remove the drill. Insert the Kyphon expander inflatable bone tamp through the working cannula and position it under image guidance. The inflatable bone tamp may also be called the IBT or balloon. Assess placement using the radiographic markers. Both marker bands should exit the working cannula. There are various sizes of the Kyphon expander inflatable bone tamp available. For example, the 20 by 3 inflatable bone tamp is approximately 20 millimeters from marker band to marker band, whereas the 15 by 3 is approximately 15 millimeters from marker band to marker band. Fix the balloon in place by inflating to 3 atmospheres, or approximately 50 psi. This will allow the balloon to maintain position while placing the instruments on the contralateral side. The supporting stylet may be removed if desired. At this point, the contralateral tools and inflatable bone tamp are positioned. Increase the volume in both IBTs in small increments, such as 1/4 to 1/2 milliliters of inflation medium. One 360-degree turn of the handle on the inflation syringe delivers 1/2 milliliter of contrast. Assess tamp size and position in lateral and AP views before proceeding to further volume increase. Use the lateral view to monitor distance from the anterior and posterior cortices. Use the AP view to monitor the lateral cortices. Continue to inflate and monitor the IBTs until an inflation endpoint is reached. Inflation endpoints for the IBT include achieving the predetermined treatment goal of fracture reduction and/or cavity creation, exceeding the maximum rated IBT pressure, exceeding the maximum rated volume for the IBT. For example, the maximum volume for the 15 mm IBT is 4 milliliters and 6 milliliters for the 20 mm IBT. Contacting any cortical wall. Note the final IBT volume as an indication of the cavity size created. Deflate the IBTs one at a time by squeezing the handle on the inflation syringe and pulling back. This action withdraws the contrast fluid. Remove the IBTs from the working cannula. The surgeon is now ready to complete the procedure.